which brings us, in fact, to the RAAS system. More counterintuitive stuff. Angiotensin converting enzyme inhibitors. Where are we with all of this, really? How does this all fit together in the big puzzle?
Sure. So angiotensin converting enzyme inhibitors were the first RAAS blockers that were being used in the setting of heart failure with reduced ejection fraction. And this is thought to be a class effect, but not the only way to block the RAAS system. So thereafter, angiotensin receptor blockers, or ARBs, came about secondarily, or after ACE inhibitors were already out on the market. Now the guidelines focus on use of ACE inhibitors preferentially, and the use of ARBs if a patient does not tolerate an ACE inhibitor. So both can be used, but ACE inhibitors are preferred.
Okay, then we have MRAs, the mineralocorticoid receptor antagonists. Where do they fit? How does this all work?
Yeah, it's interesting because you use MRAs as additive, but both target, both the ACE inhibitor or ARB and the MRAs target the same RAAS system. You may ask, why am I using both when we're targeting one pathway?
I was going to ask that. Why are we using both?
Well, I guess the thought is, and there were some data that show that even if you block the pathway with an ACE or an ARB, there's still something called aldosterone escape.
Okay.
And therefore, it needs to be inhibited on two levels, one with an ACE or an ARB, and the other with an MRA, if at all possible.
Okay, and then there are the specific aldosterone antagonists. Let's throw that in the pot and stir. How do you decide, and you were getting toward this when I interrupted you, how do you decide how to make this cocktail work? Is there a stepwise approach to it? What do you do?
So it's not an exact science. So there's an art to it. We know that we want our patients to be on all three. We want them to be on a beta blocker, we want them to be on a blocker of RAAS, an ACE inhibitor, and ARB, and we want them to be on spironolactone or Clarinone. But we can't add all of these at the same time. So we start with one, say an ACE inhibitor, at low dose. We add a beta blocker at a low dose. And the guidelines tell us that we can go back and forth, first titrating the dose of an ACE inhibitor, then titrating the dose of a beta blocker until we reach target doses that have been proven to be beneficial in clinical trials. And then somewhere along the way, we can add spironolactone. Others may add an ACE inhibitor first, and then stay with a low dose, add a beta blocker, titrate it all the way up to target doses that are proven to be effective, and then titrate the dose of an ACE inhibitor up if there's blood pressure room left to play with.
Now, I work in an ICU. All of this sounds complicated. You're dealing with patients with low ejection fractions, many of whom are sick. Do you do this as an outpatient, or do you do this to hospitalized patients? Look at this man.
You do it to both.
You do both.
You do
Thank
both.
you very much for clarifying.
You know, in the hospital, you have the advantage of having very close control of these patients. You're watching their blood pressures. If you're worried about hypotension, you at least have them under scrutiny. You're checking their pressures every few hours usually. You can make sure they're euvolemic, because one of the biggest problems when you give any of these drugs is if you dry patients out too much, which we tend to do when we're treating heart failure patients, then you give them a RAAS inhibitor, you can get into trouble with hypotension. You can control all of that in the hospital fairly well. As outpatients, you have a little bit less control, but we still have to do it.
But I think this is one of the reasons that heart failure has become the paradigmatic example of collaborative care, because we have physicians working with nurses and pharmacists to titrate this regimen over time in an efficient way with careful surveillance of laboratories so that potassium doesn't get too high and kidney function doesn't get worse. Because it's hard work, but if you're seeing patients on a frequent basis and making small incremental changes in pursuit of the goals that Orly outlined, then you can get there, and that's what we need. That's what we need to do.
So you make this disease sound dangerous. You make it sound as if you're not careful, people can get into trouble. And yet you're telling me if you're careful, you can start initiating therapy as an outpatient. Mm-hmm. And if you bring them back enough, I hear you saying you can continue to up-ramp this stuff and get them optimized. Is that fair? Or you just bring them all in and treat them for a week and send them home?
Well, you can't get all the medicines up that quickly, right? I mean, I think
that prima facie fails.
Yeah, but
it takes time.
But I do think it does help, and the data would support this, to start things. And so if you have a new diagnosis in the hospital, it helps to get the train started a little bit by starting a little bit of each of the medicines before they leave, and then letting people up titrate them in the outpatient setting.
The
And they
hospital is a good opportunity. It's an opportunity
Yeah.
because the patient is there, captive audience. It's an opportunity to see what things they may be taking, if they're at the right doses. Maybe it's, what things can be added to the regimen or optimized.
If I'm a third-party payer and I get a phone call from Dr. So-and-so, hi, I'm going to bring this patient in for a week. He's not all that bad, but I just want to sort of get his meds going. Will you pay for this? What kind of an answer am I going to get?
Probably not a positive one.
Uh-huh.
But
So who's going to pay for it?
well, the opportunity comes when the patient is in acute heart failure for another reason, and they're already in the hospital being managed for congestion.
Okay.
The oral diuretic hasn't worked. We have to use something intravenously because they've got congestion. They can't absorb their oral diuretic. So while we're diuresing or while we're removing the excess fluid, there's an opportunity to potentially start a new medicine or optimize a dose of a different medicine.
One of the things you said that scared me, I scare easily, by the way, before we move on, is if they are euvolemic or slightly hypovolemic, which is where most people run when they're being aggressively treated as outpatients, then you start this stuff. You can run into big trouble and you can make them hypotensive. So what I hear you saying, unless I'm wrong, is that you're going to start giving fluid back to people with heart failure as you work this stuff in. Did I hear that incorrectly?
Yes, you heard that incorrectly.
Thank you.
Yeah,
How
we-
did,
we're
because I
not
think our
gonna-
viewers
We're
heard
not
that
not
too.
going to give fluid back, but you have to pay attention to how much diuretic you're using.
Oh, so you stop taking
Yes.
off as much.
You might, and it really depends on where they are and what their blood pressure is doing. I mean, you have to pay attention, obviously, to blood pressure. We haven't talked about heart rate, but that's another thing that we're going to have to, at some point, discuss, because you want to look at both of these things. But this is the art that Orly was talking about. We are trying to manage a lot of balls in the air when we're talking about the pharmacologic treatment of heart failure with reduced ejection fraction.
Well, there are guidelines, right?
There are.
We
But
have
before you move on,
yeah.
actually, Peter, I wanted to also address your question where there is a difference between target dose and then optimal dose. So optimal target is based upon, the goal, what we'd like for our patients to be based upon clinical evidence, clinical trials. But optimize is based upon the patient's own conditions. So you may not even be able to achieve target doses, yet the patient is optimized. If, just say, the blood pressure is, low, systolic blood pressure of 100, and you can't titrate up, well, at that point, the patient is optimized at that moment.